Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. Please could you present the case for us?
This is a 35-year-old male. He was at the petrol station and he was hit by a 4x4 at about 20 miles an hour with a direct impact to his leg, and he was unable to weight bear afterwards. He did roll over the bonnet and then was brought in by ambulance. He's otherwise fit and well. He works as an accountant. He's a non-smoker. He was in a Thomas splint, which was applied by the ambulance. He had no other obvious injuries, though he was in spinal immobilization. ATLS protocols, like a lot of other protocols, it's A to E assessment. So A is airway, and his airway was patent. With A and ATLS, you also have C-spine. So he was in triple immobilization. And what we mean by that is bone block on either side of the head to stop the neck rotating, tapes over the top of that, over the forehead and under the chin, and then a hard collar. So that's to immobilize the C-spine in case of an injury.
You are clinically testing the C-spine by checking for bony tenderness. Do you move them as if you were just doing a survey to look at the back as well? So like, how do you get to a position where you can actually feel for bony tenderness if they're immobilized?
You can log roll them.
Okay.
So you need about 3 or 4 people. Someone stabilizes the head, and then other people get the shoulders, the pelvis, and the legs, and they stay completely the same, and they just roll over, and you can feel for the entire spine.
Very good guidelines that most emergency departments in the UK follow. So it's very clear of what the criteria are for being able to clear it clinically or radiologically, and the gold standard is the CT scan.
So all of that was fine. B is breathing. So you look for any obvious chest wall abnormality, any flail chest, bruising, auscultate the chest and look at the SATs, and all of that was fine. C is circulation. He was tachycardic at 120 beats a minute, but his blood pressure was 130 over 70. His cap refill was less than 2 seconds. He was a little bit peripherally cool, but that was all. D was disability. He was at GCS 15. He was alert. There was no sign of head injury, and he had a normal blood sugar. E is everything else.
Exposure, yeah.
Actually, an ATLS is a primary and secondary survey, really, and the primary survey is ABC.
Spinal injuries can get missed quite commonly, especially when you've got a big distracting injury like this. How do we routinely clear C-spines?
If there's no distracting injury, you can try and clear it clinically, and that would be with a lack of C-spine bony tenderness and more than 40 degrees rotation of the neck. If there's a distracting injury, and by that we mean anything that's very painful, that's going to take away from the fact that there is pain in the neck, you can only clear it with a plain film if they're young, but most commonly a CT C-spine. So he had a trauma series CT performed because of the tachycardia.
What's in a trauma series?
Usually most of the body, head, neck, chest, abdo, pelvis, and both femurs.
Pretty much areas that you have significant injury, or areas where you can have injury that's going to contribute to a major blood loss. Roughly how much blood can you lose into your leg?
I think you can lose a litre or more.
It's about a litre and a half, up to 2 litres, depending on the size of the patient. But you said his blood pressure's all right, but he's only 35 and he's a young, fit guy. So he's the sort of person who's going to stay pretty stable for a while and then suddenly drop his blood pressure as he stops compensating. Good. You mentioned the Thomas splint.
Well, you can actually see a bit of it on the x-ray there. What it is a splint that applies traction to the femur and helps to straighten it out, which can reduce blood loss as well as offer pain relief. So it starts in the groin where it's like a ring or a C shape, and it pushes into the groin, and that's how you get your counter traction. Then you've got 2 struts that go either side, and you attach it to the foot.
So you're splinting the leg indirectly by putting things either side of it and then putting longitudinal traction on the leg. That does 2 things. One is it takes any tension off the soft tissues and straightens out the leg and provides less opportunity for blood loss. And B, it's a lot more comfortable for the patient once they're in traction.
I'd check the skin, that it's a closed injury. I'd also check whether it's neurovascularly intact, ask them to wiggle their foot, wiggle their toes, and check the sensation of the main nerves to the foot and the pulses. Then you'd also assess the swelling of the thigh to give you a rough idea of how much the patient's bled into it. And sometimes the thighs can be really quite swollen and even tense. Then I check the observations, and this chap was tachycardic at 120. So I would give IV paracetamol as well as IV morphine. So I often give them diazepam as well. Yeah, and then you can add in tramadol or codeine as well as an anti-inflammatory as well. You could put in a femoral nerve block that should be fairly effective in this, but I would probably start with splinting it, giving analgesia and assessing then. In my experience, these don't always need nerve blocks.
Yeah, I agree. Would anyone like to have a stab at describing these radiographs?
The AP view shows a comminuted fracture of the shaft of the femur.
Excellent, yeah. And what can you see on the lateral? So we're looking side on at through the Thomas splint, those bars of the Thomas splint.
So I guess the distal portion has been anteriorly displaced. Is that correct?
Where's the apex of the deformity? It's a clearer way of indicating where the deformity goes to. And if you just to remind yourself, if you look for the kneecap, the patella's on the top, so you know that's anterior, so the apex is posterior. So he's got a mid-shaft fracture, as you say. Is more than one fragment or just two simple fragments?
Yeah, I mean, there's definitely more than one fragment.
Yeah, so this is a multi-fragmentary, what used to be called comminuted. We try not to use the word comminuted anymore. You will hear people using it, but we try and say multi-fragmentary because people get confused between comminuted and compound. And we try and avoid the use of the word compound as well. We say open, so it's either open or closed, and we're told that this is a closed injury. We know that there's high energy involved in this injury because you can see on his AP that this cortex is really quite thick compared to the metaphysis. So to break that cortex, you need a lot of energy. How do you want to treat this?
Initially, Thomas splint is good, but when we admit patients, that ring in the groin can lead to problems like skin problems, pressure sores. So we tend to convert them to skin traction.
So long bone injuries, we want to get on and fix them without delaying more than a day, because if left alone, they can just continue to bleed. It's very bad for their hemodynamic status. What's his hemoglobin, John?
It was 100 on arrival.
So they are a priority to get on and fix them. What would you tell him about his options for fixing this?
There's always an option of non-operative management, which I'd always give. That would be in traction for a long time, 6 weeks plus, and then some immobilization. So that is an option, but it would be very rare for us to use that. Operative options, my first choice would be an intramedullary nail, which could be either antegrade, starting at the hip, going down to the knee, retrograde, starting at the knee, going up to the hip. They're really good for mid-shaft long bone fractures. The other option is to manage this with a plate and screws. It would be a very long plate. The other option would be a permanent external fixator. Again, that would be very rare, but an option.
And what's going to be the issue with the plate versus a nail?
A nail would be a stronger construct in this because it's going down the middle of the bone. And what we're aiming is, rather than getting all the pieces in a perfect position, we're aiming to get the overall alignment of the bone right. Whereas a plate, you have to make a really big cut down the side.
The main thing is, if you put a plate on one side of the bone, you're relying on that plate to take the force when the patient walks on it. Whereas if you put a nail inside the bone, in the canal, can take the whole weight of the patient and take the force of weight bearing. So you can walk on that nail with some crutches. It's still going to be quite painful, but you can walk on that nail and have the nail bear the load straight away. What do you think this nail is? Is this an antegrade nail or is this a retrograde nail?
So this one is a retrograde.
This one is retrograde. So the antegrade nail, we tend to put screws up the neck. You going to see this guy the first day up?
So you're looking for immediate, early, late complications. So immediately, you'd want to make sure that there's no neurovascular damage. It's very rare in a nail, but it's possible. So you always do a post-operative neurovascular check. You can cause a lot of bleeding with the nail, especially because we ream up the canal to get the nail in there. and the bone does tend to bleed, and you can get oozing through the dressings. So you always check the dressings as well. Early complications would be pain, and it's really important to get on top of the pain to allow these patients to move early. And clots are quite common as well, especially in lower limb trauma. So at least 6 hours after, you'd start them on a prophylactic blood thinner. At our hospital, we use Clexane, but you can use aspirin, rivaroxaban. So if it's a simple fracture, you can be much more aggressive with weight bearing because it's much more stable. I think in this fracture, because it's a high energy, lots of different pieces, you might be a bit cautious. I think it's dealer's choice for the first 6 weeks, whether you say touch or partial weight bearing. I think after 6 weeks, you let them fully weight bear. And I would tell them you'll be feeling close to being your normal walking by 3 months, and complete recovery, you're probably realistically looking at 3 to 6 months. I think at 6 months, they could realistically back to sport potentially.
I think the impact of this injury is going to live with them for a little bit longer than that. In general, I would always counsel them longer, and then when they get back to sport quicker than that, they're really, really happy. Whereas if you give them an expectation of 6 months, that you might be leading them down a path to disappointment. I'd always err on the side of sort of a year to 2 years before they get over it, and at least 2 years before they forget about it.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at thegrandacademy@btinternet.com.